Now let's see, Roberta, can you hear me?
Yes, Julie, I can hear you well. Can you hear me?
Okay, very good. So maybe I give the floor to you straight away, and you can start moderating your session too.
Thank you so much. Thank you so much, Julia. Good morning, good afternoon, and good evening to all. Thank you for joining us in the second session of the London Global Cancer Week. I have now the pleasure to welcome my dear colleague, Dr. Julie Chiaro, who is a pediatric oncologist practicing in Australia Royal Children's Hospital in Melbourne. And she has been also supporting our work at the Global Initiative for Childhood Cancer since 2020, and is working alongside our team in leading the WHO global campaign for the meaningful engagement of people affected by cancer, which is a campaign that was launched a year ago, trying to value the expertise, the perspectives of the people with lived experience to help us co-create policies and programs and services that fundamentally meet the needs of the people affected by cancer. So welcome, Julie. The floor is yours.
Thank you, Roberta. Let me just share this. Thank you very much for the opportunity to present this campaign. Can you see the slides?
Yes.
Okay, and I'll just put this down
9%
here.
remote.
Yeah. So we'll briefly introduce, for those of you who haven't heard of this WHO campaign, as Roberta said, engaging people with a lived cancer experience. As Andre has very well said, amongst these times of conflict, it's absolutely fundamental that we're able to take stock and listen to the people who are the ones affected by cancer. So the aims of this project is not only to listen, but actually to include people and to engage individuals with lived experience in the co-creation of policies and health services, which can then be specific and appropriate to each context and can be individualized to each country. The other big aim of our of this project is to listen and hear from people, documenting mainly the psychosocial and the financial needs of people during treatment and far beyond treatment, identifying then the gaps in the support that they have or are receiving. This campaign aligns with the WHO framework on the left here for meaningful engagement of people living with NCDs, which has the objective to support WHO and member states in, as the title says, engaging people in the co-creation of programs. It also aligns with these SDG targets, which look at ensuring responsive, inclusive, and participatory decision-making. As you can see here, we're still at the start of this project, which we expect will last year. The first phase was an extensive literature review identifying gaps in the literature. And we know there is a lot of literature on psychosocial mental health, as we've heard from Wendy, impacts of cancer, as well as financial toxicity. But unfortunately, a lot of this data is still from high-income countries. There's also data missing from certain people affected by cancer, such as bereaved family members, and also from survivors and their family members long-term post-cancer diagnosis over 10 years. There's not a lot of literature on this. And as well from communities such as the ones we've been hearing about today in conflicted areas. So our objective is to gather information from these people, which can then inform priorities. And this will be done through a global survey. We're hoping that this will then enable us to host community dialogues, which will then permit to add local specificities and best practices from different parts of the world and identify and create policies that can then be implemented at the local level so that these can be really people-centered and co-designed by people affected by cancer themselves. So the objectives of our data collection phase were, as we said, to understand immediate and long-term impacts with a focus on psychosocial and financial impacts, and importantly, globally, on people with cancer, as children and as adults, their caregivers and bereaved family members. We hope that this will help us propose research priorities and define interventions and policies, including in countries in crisis. The methods of this is through a cross-sectional survey, which was developed with content experts, but also with people with lived experience themselves from different parts of the world, and which is distributed by WHO headquarters. The recruitment is through purposive sampling, and here we have to really acknowledge and be grateful for all our partners that are helping disseminate the survey. The survey is based on the WHO Quality of Life Framework, which a lot of you will be familiar with, but actually includes a lot of items from validated questionnaires that touch on things such as financial toxicity, but also policy supports in terms of employment, access to paid leave, and then more medical questions in terms of physical impacts, mental health impacts, and access to survivorship care. It was piloted last year in 3 languages, and this year we've been working on editing the survey based on stakeholder and partner feedback, but very importantly on about 550 participants' feedback, which gave us very valuable ideas on missing questions and wording through some open-ended questions. It's been expanded to include people currently receiving treatment and their caregivers, and we're hoping to be able to translate it in all of the UN languages as well as other potential languages. So a lot of opportunities for engagement for the community in survey translations and in dissemination. We really need everyone's help to be able to hear from all of the communities and the experience around the world. We are hoping then to host local dialogues to discuss the results and add specificities from each context, and then hopefully identify and define interventions that can be in the final phase implemented in country. So thank you very much. Please do get in touch if you'd like to hear more. My email is there. You can also email the GICC email, and we look forward to sharing the dissemination of the survey with you, the release of the survey, and then the results.
Thank you very much, Julie, for updating us on the current status of the global campaign. And also, as you can see from the chat, our colleague Julia has shared the access to the webpage where you can learn more about the global campaign and engage with the survey. As we have been hearing from both Julie's presentation, but in the previous session, nearly every family globally is affected by cancer. At least 1 in 5 people are diagnosed with cancer during their lifetime, and understanding and amplifying the lived experiences of people affected by cancer can help us create more effective and people-centered care. Now it's my pleasure to welcome Professor Richard Sinha from Macmillan Cancer Support UK to help us understand how better to address the needs of those affected by cancer. Welcome, Professor Sinha.
Thank you very much for the invite. For the benefit of this audience, it's probably, could you just stop sharing so I can bring my slides? Thank you. For the benefit of this audience, it's probably just worth explaining that Macmillan Cancer Support is the largest cancer support organisation in the UK, and our mission is to ensure that people living with cancer are able to live life as fully as possible. And the brief I was given is to ask what really happens when a person is diagnosed with cancer. And what I want to try and say today is that personalised care, wraparound care, should have a parity of esteem with physical care, and that personalised care should not be seen as a luxury good, but rather as a basic right. I like this definition of what really happens. It's the experience of living with, through, and beyond a diagnosis of cancer. That's what we're talking about. And that's the definition of survivorship used by the National Coalition for Cancer Survivorship. Survivorship itself is perhaps a contentious term that brings up metaphors of fights, battles, and conflicts that we know people use in their experience of cancer, which in the context of today's conversations is probably not helpful. So I prefer the term of living with and beyond cancer. We've also been talking about precision medicine, which is a way that we're going to improve the outcomes for people living with cancer by focusing on genomic instabilities. But actually what we really want to make sure is that we have personalized medicine that's designed to meet the needs of an individual patient. Precision medicine is what's the matter with the patient. Personalized medicine is about what matters to that patient and what we should be focusing on. Precision medicine is something everyone seems to be talking about. Personalized medicine is something that nobody should forget. So what does happen when someone is diagnosed with cancer? I always go back to this quote from Susan Sontag. where she talked about you entering a new world, the kingdom of the sick. The moment of diagnosis is the border control, where your life is changed. We've just talked about post-traumatic growth, and the diagnosis of cancer is a trauma. The US oncologist Mark Lewis, when he was diagnosed with his own pancreas cancer, described what he called the tinnitus of terror, the moment of the diagnosis, meaning that he could no longer hear or think or ask the appropriate questions, despite being an expert himself in cancer. People affected by cancer need support in those moments. But when Susan Sontag wrote Illness as Metaphor, she was asking that we don't use metaphors. We give citizens, societies, and individuals the information and clarity they need to be able to deal with the cancer diagnosis and to live without fear, because cancer is not only a threat to life, but it's a threat to living well. The moment of cancer is a drop in a pond. It starts ripples which affect work, family, friendships, their own influence and capability within society. And all of those are relevant to the medical professionals and societies that care for them. At Macmillan, we've defined the different stages of a person's cancer diagnosis as times of need, from receiving a cancer diagnosis to living with treatable but not curable cancer and eventually dying of that disease, or recovering well or not so well with long-term effects. And we've identified needs throughout that period. We use something called holistic needs assessment. It's a battery of 65 questions that are offered to all patients in the UK after a cancer diagnosis. This is a list of prevalent concerns for women affected by breast cancer, showing that the biggest unmet needs are worry, fear, and anxiety, tiredness and fatigue, but also issues of money, finance, thinking about the future. At Macmillan, we've grouped these types of need, personalised need for people affected by cancer, into 6 groups that we can see on the screen there. Spiritual and religious need also encompasses fear of dying, searching for a greater meaning of life after cancer diagnosis, and feelings about faith and religion. Physical needs have been well articulated, and I want to just focus quickly on physical, emotional, financial information. The need of people affected by cancer for information is vast, and it's a need we very rarely absolutely fulfill. This is old data from my own university showing that people affected by cancer absolutely need and would like data on all possible treatments, possible side effects, and how treatments work to treat the illness. This is more recent data showing that you cannot predict a person who will not need information. You cannot predict it by education level, by age, or by gender. Everyone has the right to high quality information, and they desire and demand it. Physical needs cover a wide spectrum. We recognize the physical needs very well during therapy, but after therapy, we're often less good at identifying those needs which affect a person's ability to return to economic activity within their own society, such as fatigue, memory issues, bladder, bowel, and intimacy problems that affect personal relationships. Emotional needs are very high. And once again, sadness, anxiety, depression, loss of libido are very well surfaced through holistic need assessment. And we can identify that these emotional concerns are poorly met and are not predictable by gender, age, or employment status. Financial needs are something that have preoccupied us as a cancer charity, and we've talked a little bit about financial toxicity already this morning. Our own work shows that a patient in the UK will be disadvantaged financially to the cost of around £600 per month, and even in a society that has socialised medicine. Some patients may be very more greatly affected by that. Once again, not easy to predict by gender, age, or other disease conditions. And financial toxicity is a very major strain globally, and even in a society with socialised medicine available. We've learned through our own provision of personalised care that the needs, the preference for support and the availability for support changes over the course of a patient's cancer experience. At that initial shock stage, it may not be possible to give good, high quality information simply because the person is not able to receive and absorb it. Active check-in and support with a key worker is a model we use very well in the UK. Online support and phone consultation and online suites of resources for people who need different information resources at different times. And we also recognise that the ability for people to support people, peer support, is very important, and providing the infrastructures that can do that as people approach a new normal is important. We're not the only people to recognise this. There are survivorship schemes globally. The European Cancer Code has a very good battery of aims, and the reintegration into society is a noble aim that I think we should all be looking at. This is an Australian framework which looks at similar things. This was the Macmillan framework that we adopted, looking at supporting people back in terms of managing the consequences of treatment, giving them the financial and work and support they need, and promoting a physical activity and healthy lifestyle, using their cancer as a teachable moment for other health style and lifestyle changes. But notice that it's surrounded by supporting self-management, making the citizen themselves the architect of their own recovery with our support. We know as a charity that we can't do that alone, and that the fact that the third sector globally has recognized personalized care and support is vital means that there's been an absolute explosion of charities that wish to support personalized care and support. And I would recognize that this is a global problem that requires local solutions, and local solutions are going to be best identified by collaborating with third-party sectors who understand those environments. So what really happens when a person is diagnosed with cancer? Those lives are changed. It creates ripples throughout a society. And the holistic needs as a consequence of that are potentially unmet unless we ask the questions and build the infrastructures that allow us to answer those questions once we've asked them. And personalised care should be seen as a basic right, but rather than as a luxury good. Thank you.
Thank you very much, Professor Singham, for sharing this insight on the importance of how to provide holistic care and address different typologies of needs of people affected by cancer. So now moving on with our program, as we have been introduced by Professor Singham, we will have now the opportunity to receive a person with lived experience, as we clearly learned today, a person who's living with cancer beyond the cancer diagnosis, who's a representative from Childhood Cancer International, one of our major implementing partners for the Global Initiative for Childhood Cancer. So it's my pleasure to introduce Cesar Medawar to take the floor. Welcome, Cesar.
All right. Can you hear me?
Yes, we can hear you well.
Okay. Could I just bother you? Yes, I want to share my screen. Just 1 second. Please, can you let me know if you see it?
Yes, we do.
Okay.
Just in, yeah, now presenter mode. Thank you.
Is it good? Okay. Now, I want to thank you all for having me today. It's a true honor to be here. I'm just going to introduce myself briefly. My name is Cesar. I'm a fifth-year pharmacy student at St. Joseph University in Lebanon. Now, beyond my academic journey, I'm a two-time cancer survivor. At the age of 15, in 2016, I was diagnosed with Hodgkin's lymphoma, underwent treatment, and unfortunately experienced a relapse in 2020 at the age of 19. Now, currently, I am, thank God, in remission and deeply grateful for the tremendous support I received. The support came primarily from the Chance Association, the incredible generosity of individuals such as my parents, their co-workers, friends, and even friends from friends. Every day, I'm reminded of the profound impact that their support had on my treatment recovery. Now, concerning, are we doing enough by just focusing on treatment technologies? Now, I can just show you, like in my situation, in my country, what really happens. Now, you all know the situation in Lebanon. I'm just going to introduce it briefly. Lebanon faces right now an array of challenges post the 2020 Beirut explosion, with economic and political turmoil exacerbated by the devastation. The economic downturn, characterized by the devaluation of the Lebanese pound, hyperinflation, shortages, underscores the need for comprehensive healthcare strategy. Treatment technology alone is insufficient, and it is crucial to address comprehensive healthcare issues in Lebanon, including public education, prevention, regular checkups, managing risk factors, stress management, and ensuring affordable or covered medication provision for the people that do not have the possibility to pay for it. Now, the aspects that should be taken into consideration, aside from the technologies and the development of treatment technologies, is the issue, for example, of adherence to cancer treatment for patients in Lebanon particularly. Now, a 2022 study titled Barriers of Adherence to Cancer Treatment Among Head and Neck Cancer Patients outlines various factors contributing to non-adherence across different dimensions, many of which resonate with the challenges faced in Lebanon. In the socioeconomic dimension, for example, you can see Lebanon contends with prevalent issues such as poverty, illiteracy, low levels of education, unemployment, and transportation challenges. As of early 2022, the United Nations actually estimated that approximately 80% of Lebanese individuals lived below the poverty line. Furthermore, a recent survey by Lebanon's Central Administration of Statistics and the International Labour Organization revealed that the country's unemployment rate surged from 11.4% in 2018 to 2019 to 29.6% in January 2022. That means that almost 1/3 of the active labor force was unemployed in January 2022. Now, the escalating levels of poverty and unemployment in Lebanon have led to a decline in education accessibility. Many parents grappling with economic challenges cannot afford to send their children to school, resulting in lower levels of education among the population. Compounding these difficulties is the ongoing fuel crisis, making transportation extremely challenging for cancer patients who may lack the fuel necessary to travel to clinics for treatment, especially if they come from villages far away in the south or the north. These interconnected socioeconomic factors underscore the urgent need for a comprehensive approach to ensure that cancer patients in Lebanon can overcome barriers to treatment adherence. Now, these numerous challenges in Lebanon bring attention to another critical factor: stress and chronic stress. Now, stress, especially for the population in the southern regions amidst political conflict right now, with the problem with Gaza and everything, it's essential to recognize that psychosocial stress and anxiety significantly contribute to the non-adherence to treatment, and that on the other hand, as research shows, such as the study Chronic Stress Promotes Cancer Development from August 2020, and Interplay Between Stress and Cancer, a focus on inflammation, published in March 2023, they both highlight that chronic stress can initiate tumorigenesis and play a role in the development of cancer. These studies delve into the molecular mechanisms that elucidate how chronic stress fosters cancer progression. This underscores the importance of addressing the psychological well-being of individuals, particularly in regions facing heightened political tensions, as an integral aspect of comprehensive cancer care. Now, on a personal level, I can't deny feeling a deep concern, not just for myself, but for the well-being of all cancer patients and survivors in Lebanon. The current situation is far from promising here. There's an evident lack of proper care due to shortage of medication. Actually, there's been numerous protests and expressions of concern that have been voiced by both patients and healthcare professionals, highlighting the widespread issue of medication shortages in Lebanon. There's been financial constraints and a looming threat of political instability or even war, which could disrupt essential medical services. Drawing parallels with recent events such as the Ukrainian-Russian conflict, as highlighted in the August 2022 article, The Armed Conflict and the Impact of Patients with Cancer in Ukraine, Urgent Considerations by the American Society of Clinical Oncology, they underscore the potential dire consequences of treatment delays due to war that could stop hospital and care service. The impact of such delays on mortality has been quantified and demonstrated by the data presented in October 2020 article, Mortality Due to Cancer Treatment Delay, which shows that even a 4-week treatment delay is associated with tremendous increased mortality. The urgency to address these challenges and ensure timely access to cancer care in Lebanon is paramount. As a medical student who deeply appreciates the significance of a well-established and respected cancer treatment protocol, I harbor concerns about the possibility of experiencing maybe a relapse in Lebanon, not just for me, but for everyone, because the apprehension stems from the uncertainty of accessing the appropriate treatment, which may not be readily available here. Additionally, there's a fear of facing external factors that could impede the continuity of treatment or compromise its efficacy, like not having enough fuel to get to the hospital, not having the right medication, or war shutting down hospitals. After chemotherapy, for example, to put things into context, I'm going to tell a story from mine. In 2020, for my second treatment, after my chemotherapy treatment, it was necessary to consider a transplant, a bone marrow transplant. We went to the AUB, the American University of Beirut Medical Center, to first obtain a cost estimate. A figure of 15 million Lebanese pounds was initially set. 2 or 3 weeks later, when we entered for the operation and the transplant, me and my parents, the figure had doubled while my parents' salaries had not changed. We had to negotiate and stand firm against the inflexibility of the administration, which became more flexible after lengthy negotiation. I now firmly believe that no cancer patient or their family should be into any situation where they have to negotiate for the essential treatment they require. Battling cancer is already an immense challenge on its own. I consider myself exceptionally fortunate to have completed my treatment before the situation worsened, and I can't fathom the challenges Lebanese cancer patients must face in accessing treatment amidst the ongoing crisis, coupled with the looming threat of war that could drastically alter the course of their lives in a devastating manner. Now, just to briefly conclude my presentation, I want to present the association that first thing first helped me get the treatment I deserve, and which I'm part of. I'm associated with them. It's Chance Association. Chance Association was established in 2002 and has been dedicated to a singular mission: saving the lives of children with cancer. This involves ensuring access to state-of-the-art care by covering treatment costs, conducting awareness campaigns against cancer, providing support to families and children through activities to alleviate their distress, and contributing to the understanding of cancer through impactful research. Chance operates as a non-profit organization officially registered in both Lebanon and Switzerland. Through close collaboration with key partners in the medical industry, it delivers quality care. Importantly, Chance is non-denominational, apolitical, and non-religious, committed to assisting children and their families in overcoming and fighting cancer. Having supported a total of 800 children and currently aiding 120 more across 9 hospitals, Chance acknowledges the challenging situation in Lebanon. Now, with the country facing inflation, medical shortages, and escalating medical costs at hospitals, and reduced funding from the National Social Security Fund, families are undergoing immense stress and immense distress. Now, despite the hardships, Chance strives to support these families and make a positive impact. However, the current scenario has created a widening gap between costs and donations, jeopardizing their ability to provide the same level of care as before. So in these trying times, Chance urgently needs all the support it can get to continue saving the lives of these children. And I want to thank you for your attention, and thank you for all listening to me. It was truly an honor and a pleasure.
Thank you very much, Cesar, for sharing this valuable experience. And also I want to acknowledge the presence of our colleague Rula Farah, who's also been supporting the work of Chance. And I think that this is a great opportunity for us to understand as a global cancer community how we can learn from this experience in your expertise to inform policies, but to open up more spaces for dialogue so that you can have active participatory participation in the policy dialogues to, as you mentioned, the importance to reduce financial toxicities for families, and particularly in this challenging settings. And now moving forward with the program, we would like to introduce our colleague from the International Agency for Research on Cancer, Salvatore Valcasella, who has a vast experience in studying social inequalities and cancer, to present about the lived experience as exposure of inequalities. Salvatore, welcome. The floor is yours.
Share my slides. Please kindly let me know if you can see them on a full screen. Is it okay?
Yes, Salvatore, but not yet in the presentation mode.
Can you
Excellent.
see them? Okay, great. Okay, so I'm going to discuss today what some of them. Okay. So I'm going to discuss some of the issues that the health system are facing according to our work that we do, in particular the undersupply and oversupply of medical care. And this has implication, in particular, with the previous talks we had. I would like to emphasize the socioeconomic axis is never emphasized enough. But in our health system, usually we face the paradox that we have both at the same time, the coexistence of undersupply, and oversupply. Undersupply refers to lack of delivery to medical services to people who need the most, where the burden is highest, so people with low socioeconomic conditions. And on the other hand, oversupply refers to the fact that those that have higher access to the healthcare, sometimes they are exposed to low value care, which might be expensive, very expensive, and might have little benefit, or might be unnecessary or even harmful. So I will show you some examples. And this certainly is not, this data that I show you are somehow indirectly relating to all countries, also the countries in conflict, in a way to how medical services should be prioritized. So we cannot avoid to discuss the structural determinant of cancer and of health, our societies and the way they are designed, and the health systems. They are determinants of the way individuals behave, and they are made so that the more affluent people do on treatment and prevention, and whereas the less the most disadvantaged are less favored on this. So to use an example of the football pitch is like if this is unleveled, and but the steepness of this football pitch might vary across population and across countries. And this is interesting because it might serve as an example for other countries of what has been effectively achieved in terms of health. With respect to cancer, we know that everywhere people with low socioeconomic condition have higher probability of dying, higher or much higher probability of dying from any type of cancer, basically, practically all cancer types. And this is true in every country. Ironically, or maybe because of that, the cancer with a stronger socioeconomic gradients are those for which we have an effective prevention measures. And these are cancer associated to tobacco smoking, or for instance, cancer like cervical cancer, for which we have screening and vaccination that can reduce the burden of incidence and mortality. This is an example of some data in Europe. We can see that everywhere inequalities exist. Low socioeconomic condition people have higher or much higher mortality rates compared to high socioeconomic people. There is a gradient, which means that a social gradient, which means that everyone in the population is affected, not only the very disadvantaged population. And what is interesting to see is that, for instance, if you focus on pharyngeal cancer, this is an example, but and it refers to what Cesar was saying, the socioeconomic, the importance of socioeconomic factors, because those that are better off seems to do relatively well no matter where they live, whereas for other people, for the most disadvantaged, is important where they live. This is another set of cancer that I'm going to show you, and it shows that basically in every country and in every for every cancer there are inequalities, but the magnitude of these inequalities might vary substantially, and is interesting because it provides the potential for prevention. So socioeconomic inequalities are very important. This study has been done in Europe and has been observing that, quantifying that 1 in 3 cancer deaths in men and 1 in 6 cancer deaths in women are associated with educational inequalities. This number grows substantially when we focus on the least developed countries in Europe. So this number goes to almost 1 in 2 men and 1 in 4 women are dying of cancer because of associated socioeconomic inequality. So these are important numbers, and this could be, there is no need and there is no fear that these inequalities occur, and they could be prevented. So on the other hand, so usually we focus on undersupply, but in the same society, sometimes there is not enough focus on those people where the burden is highest, but there is the tendency in some cases to have an oversupply of medical services. So as I mentioned before, we will see a couple of examples. And this oversupply might lead to over-medicalization, which is usually is occurring everywhere as well, but usually it occurs where the healthcare system is more disorganized. And it occurs because very often there is a divergence between what are the evidence-based recommendation and the actual implementation of this recommendation, which might be very different. It is due to cultural factors or to the technology spiral, the need to use technologies once we have it. Is due to commercial incentives, and I think this afternoon we will see a nice session on commercial determinants of health and of cancer. But it might undermine the sustainability of the health systems, especially in these days. You know, we always hear the news that the health systems are suffering from lack of medical doctors or from very long waiting times and so on. And so this over-medicalization might represent a waste of human and financial resources. Importantly, it might harm a lot of individuals, particularly those with a higher access to the healthcare. Some examples are, I will give you, are the overdiagnosis and overtreatment to certain cancer. The first one is thyroid cancer, and thyroid cancer was a very rare cancer until a few decades ago, but suddenly we have seen a very, very quick rise in incidence in the US first, and in France, and in other countries like Italy, in correspondence to the introduction of ultrasound and other imaging machines. Mortality rates remain the same, actually decline a little bit, and they were very low. We have seen something even more spectacular in Korea, with an increase in only 10 years. The rates have been increasing like something that's never seen before. The reason for this are that there is a possibility with the imaging machine to detect very, very small nodules, which are present in 10 to 20% of each of us. These nodules, they do not advance. They do not cause any symptoms, and especially they do not cause death. And there has been an increased surveillance, which has been favored by the disorganized implementation of this screening. But the disorganized implementation of this screening, all the guidelines recommend against screening for thyroid cancer, but still there is, despite these guidelines, there is still an ongoing opportunistic screening, and this cancer has become the most common cancer, one of the most common cancer, the second among very young women in many countries in the world. So we heard before about the consequences of cancer. We have psychosocial consequences, of course, which are terrible. And in the case of thyroid cancer, we have the removal of the thyroid, plus in 50% of the cases, radioactive iodine treatment, and so on. There is financial toxicity. We heard before about it. And this is all unnecessary. This is applied to individuals that should not have been diagnosed in the first place. And there is a waste of resources, of course, for the health systems. And in particular, I will show you some figures soon. The individuals mostly affected are young women below age of 50, but also more and more adolescents are affected by this. It's a study we did over the years. We estimated that between 60 to 90% of these cases are overdiagnosed. And this phenomenon is expanding in many places like East Europe, Central Asia, China, Brazil, India, Turkey. These I mentioned are all countries with relatively disorganized health systems and where a lot of opportunistic screening is allowed and is favored. So a lot of people are affected by this, and that cost. When we talk about cost, only in France for 5 years we have estimated between 60 to 110 million, only direct cost, but including the indirect cost, probably this number would double, would go up to 250, 300 million euros wasted to overdiagnose people. So this is one problem. Another possible problem in the over-medicalization might be the fact that there has been a lot of disorganized screening of the prostate with the PSA in the past, and this has led to probably to a certain reduction also in mortality. Is not clear together with treatment. It is difficult to disentangle the two effects, but certainly it has led to a very high incidence of the disease of prostate cancer. And we can presume that that there is a lot of overdiagnosis going on, which means a lot of people have been diagnosed with prostate cancer and have been operated for prostate cancer, and so on, with a lot of the negative consequences in an unnecessary way. And this is also implication for how countries should prioritize intervention. And when they decide about an intervention, they should make sure that recommendations are strongly followed and so on. So in this talk, I wanted to put out a reflection on how to rebalance the health systems and to think about the undersupply and the oversupply and so on. Thank you very much.
Thank you very much, Salvatore, for this very informative presentation. And unfortunately, as we are moving a little out of our scheduled time, I would like to invite now Dr. AJ Agarwal to coordinate the moderated session. That will be the last session of this second part. It's very important for us to stick for the time. So over to you, Dr. Agarwal, for your moderation.
Thanks so much, Roberta. Hopefully you can hear me, everyone. Can I just check how long we have for the session? I've got my timer ready, so you'll hear that. We got 15 minutes, do you think? Yeah, okay. So, I mean, excellent set of presentations. Thank you so much, Giulia, Cesar, Richard and Salvatore. And I think what it comes down to is that we go to all these conferences and all we see are Kaplan-Meier's progression-free survival, median overall survival. But we've actually had an hour talking about the lived experience, what actually matters. And actually, when you hear it, we're missing a trick here and we really need to expose that. And so I want to give an opportunity to ask a few more questions of our speakers. If we could stop the share screen, and I think then we'd be able to see the speakers more clearly. So if I could start with Julie, actually, if you're still online.
Yeah, I'm sort of in and out, but I'm still here.
Okay, just a quick question for you. I mean, you talked about the surveys, and there's lots of components, aren't there? There's cost of illness, there's experience, there's functional. How confident is one with surveys that you're actually hearing the real truth as such, as opposed to doing qualitative research, for instance? Where do you stand on that, and how can it inform policy, what you're doing?
Yeah, so that's a great question. I mean, so most of the questions are more qualitative but we did include quite a number of open-ended questions, especially asking for, broader impacts that we hadn't addressed and things like that. There is also an opportunity for participants to provide their contact details, and we do hope to then be able to follow up with some interviews at a later stage. It's just not something we can promise right now, but there probably will be that option in the future as a complement.
Fantastic. And what countries are you starting this off in to begin with? People, very interesting.
It's no particular target, so it'll be open in a few languages, and it'll be globally available.
Fantastic. Thank you. Richard, if I could come on to you. You articulated very well what survivorship is, what personalized medicine. But you're right, survivorship can be militarized, personalized medicine can be called precision medicine. How much do you think that's holding back the context, understanding of the patient voice in this, the fact that it is used maybe in marketing language, etc.? Where do you stand on that?
I do worry. It's why I always try to amplify that distinction, that we should never confuse one for the other, and that person-centered care should always be what we're aiming for. I worry that as medical care becomes more complex, we get deeper into silos, and start to think that personalized care, the holistic care of individuals, is someone else's business, that those sat in tertiary care think that primary care are looking after the person, primary care thinks the person's in hospital, so the hospital are looking after the person. And unless we ask the questions, unless we take a responsibility for surfacing the question about what matters to that person, we'll never know. So it has to be everybody's responsibility to have, and I do think that we have to systematize that question. In the UK, we've moved to a personalized care agenda where people are supposed to have a holistic needs assessment. So we're supposed to be asking the question at a routine, but we know that it gets forgotten. We know that it gets drowned out by the sheer volume of other work. So it's our job to advocate constantly for personalized care and asking the right questions to be brought to the top of the healthcare agenda.
No, I think that's well said. And I suppose when you were going through all the different elements, financial, emotional, the data, the physical, there's a cost associated with it. If you're an economist, you'd say, well, actually, that costs that much to the health service, this comes much. Are there any examples of this being survivorship being formally costed in national cancer control plans, or countries who might do it better that we can learn from? Because not sure of any at present.
No, we haven't seen survivorship well costed in a way that improves the economics of a country. We've seen quite a lot of work in our own work. In Scotland, we've been doing something in the Improving Cancer Journey, which is embedding survivorship in communities, not just making it a hospital business, working with civic and local groups to make sure that survivorship care is embedded in communities. 76% of our referrals for that come from financial advisors, people who are in financial distress. As a consequence of that, civic and third sector groups in the community support those cancer patients and get them back to work. And we have good evidence of return to economic activity for those people affected by cancer, which is good for their societies, but also good for them as autonomous individuals. But costing it as a national system, we've not seen that.
And do you think there would be appetite for it? I mean, we do all this cost effectiveness analysis, budget impact analysis, but actually the lived experience as treatments get better for the next 5, 10 years plus is not there. What can we do?
I would love to see that. If we can supposedly afford a drug with minimal impact on progression-free survival on the basis of a QALY, I find it extraordinary that we couldn't demonstrate a QALY for improving a person's life in terms of their sexual health, their physical health, and their mental state.
Thanks, Richard. No, absolutely. Cesar, if I could come. Sorry, Cesar, if I could come to you. Really brilliant presentation, just at the sort of guts of what everything's about, really, where we've got these inherent system issues, which if we don't sort out, it doesn't matter what treatments you have. I suppose you gave and you were very cognizant of it, about the situation you were in, of being in an empowered position to having to negotiate, and others might not be able to. But I wanted to ask a more broader question from your own context, is how can we start to build in more meaningful involvement of patients in policy, in highlighting these system issues, particularly as you mentioned adherence? How do we have that sort of co-creation element in policy, do you think, from your perspective?
Could you please repeat the question?
Yeah, so I was just saying that you articulated the situation that you found yourself in, that there are issues in terms of barriers to adherence, lots of system level problems, costs, etc. Part of that, I think, is because the patient perspective is not understood from a policy perspective, or it's not integrated. What I was trying to ask is, how do you think patients can become more, or people with lived experience of cancer can become more integrated in developing the service or working with policymakers?
For the broader aspect, now the problem is with these things, you have to focus on them. To start focusing on it, you have to have a well-working country, you know? In countries where it's difficult, where there's war, there's no space, there's no time to make like these efforts. Do you understand what I mean? Like when there is war, there is no like priority on what the patient thinks or what is best suited to make the patient go through his cancer treatment in the best way possible without having any trauma or pain. Now, the first things first is that you have to solve the problems of the country, make it more developed, and then you can focus on the more minor detail. Now, something that we could focus on, for example, now from my perspective, that could make going through cancer treatment more easy for cancer patient, is that being more open about communication between the patient and the doctor. For example, I'm gonna say from my own experience that the first time was for me more of like a fairy tale. I didn't really understand it. I was just an adolescent. I was just a kid. The second time was more difficult. Now the second time, nobody really told me what I was gonna go through. They like minimized the difficulties that I was gonna go through. They said that it was gonna be easy. It was gonna be fast. Now, one thing that we could actually implement now, even though there's war or there's conflict or there's socioeconomic crisis, is that become more open with the patient, more honest about what's going to happen. Like if a patient asks the doctor, will it hurt? Is it going to be long? Is it going to be difficult? I would have preferred that my doctor or my doctors in general would have told me more honestly that yes, it was going to be painful, it was going to be difficult, because when I actually got to the treatment, which was specifically the bone marrow transplant, I honestly thought that it was going to be like just a day or two. Then I understood that it was going to be a week. Then it became 3 weeks. And I thought it was going to be easy, like the other cancer treatments. Turns out it was going to be way harder. And it was honestly the worst 3 weeks of my life. Now, I don't really know if I really responded to your questions. You could tell me. So
no, you responded to it perfectly, and I think actually that's a very pragmatic way that communicate has to start with good communication. You mentioned around, well, the systems have to develop to have to get more meaningful engagement. I suppose another question is, and it may be something that you've experienced or seen, is how patients or people with lived experience can form a network to support that process. Has that happened at all? I know you mentioned the initiative earlier, but is there a forum or something that can be created where patients have an opportunity to ask questions from those who've had lived experience?
Well, of course, maybe you could create like a forum, an internet forum or a site where like newly diagnosed cancer patients could ask survivors their opinions and what they've been through. Maybe there could be categories where Hodgkin's lymphoma or breast cancer, and cancer survivors actually explain what they've been through and explain in detail how it's going to be, how they're going to feel and everything. That could be a step. Now, other things that we could work on is maybe providing more medical care from the associations and everything from outside, providing medical, making it less difficult for patients to actually. Now, this is something that was very traumatic for me when 3 years ago, that the bone marrow transplant was already serious enough for me. Now, when I got to the medical center, I got really scared because like negotiating like prices, it really put me at risk. Like I was like, okay, maybe I might not get the care that I need. Maybe I'm gonna have to go home and delay my treatment. And I know how important it is because my doctor was very strict, and she was a great doctor, Dr. Rula. She was a great doctor. She was very strict about my protocol. She said that, yes, you got to do this, you got to do this time and this time. And it really got me scared that maybe I might not be able to respect the protocol fully. And I think this is very important because trauma can come from like the idea of, oh yeah, I didn't get my treatment so perfectly. So maybe there's been like a mistake or something, or the treatment wasn't as efficient as it should have been. So maybe cancer will come back. This is something that we should focus a lot on, about psychological impacts of treatment after the treatment. Because I'm going to be honest, like personally, I didn't move on from my cancer till now. I still didn't move on psychologically from it.
No, Cesar, thank you for being so honest with us. I've got a couple of minutes just to ask Salvatore. I just wanted to get your thoughts. A lot of what displays as the social determinants, you're preordained to get cancers linked to tobacco, poor lifestyle. Equally, there's overuse of treatments by those who are well off. Where do you stand from a policy perspective of vertical intervention? So particularly ensuring those resources are pulled towards those from lower socioeconomic groups. It's not necessarily equal access for equal need, but unequal access. Where do you stand on that? And have you seen good examples from a policy space of it?
Well, thank you very much for the question. I think the first point, in my opinion, would be to recognize that there are these differences in inequalities. Still, I don't think this recognized data. Okay, we know that it's not only a matter of data, but there are not enough data to bring to the policymaker so that they get convinced. Unfortunately, the economic, there was a nice citation, but the economic impact is also very strong. So it's important to bring also economical figures. Reducing these inequalities reduces also the cost. And so I think the first step would be still raise awareness that socioeconomic factors are the most important factors explaining all the distribution of cancer all over. So I think that would be the first step.
Thanks, Salvatore, and I think IARC are doing tremendous work in that space. I think that is it for the session. Thank you so much for the talks and engagement. I'll leave it to Roberta to finish us off. Thank you.
Thank you so much, AJ. And thank you to all our distinguished speakers. You have reminded us how our diagnosis of cancer is a life-changing journey, particularly through the powerful presentation provided by Cesar. But I think it's also we see this opportunities to engage young survivor networks, patient advocates. Your voices have the power, and to provide more participative spaces for the advocates, for the survivors, to participate in policy dialogues, to help us use your expertise to shape policies and to develop better patient-centered care, holistic care, as I was exemplified through the work by Macmillan. So on behalf of our team, I want to thank all the participants to this session for joining us today. And I think I will then ask Julia, what time are we starting the last session of the afternoon? So I believe we have around 10-minute break, and then we will get started with the next and the last session of this event. Over to you, Julie.
Thank you. Thank you very much, Roberta. Thank you very much, all the speakers, all the participants, all the attendees who have been with us. Indeed, we have now a 13-minute mobility break. Please take your time, go and stretch and have something to drink. And we will start again at 13:30 with the commercial determinants of cancer.